which are, very, very bright people out of NASA and JPL and Caltech. We have all these really fancy ways of looking at an angle, transducer, reproducible angulation. And, we got into GPS, and 3D stuff. I mean, it was just incredible science. It was fun, but it's worthless because, once again, patients change. You get fatter, they get skinnier. You never get them on the table the same way. So we went back to the drawing board and we started to think about this a little bit. And really the best way that we came up with to do this is to use internal standardization procedures. So each individual's anatomy is really the guide of how you get back to proangulation. Now, it's not, I think that we can't determine what the differences in angulation and azimuth directions are, and if that really makes a significant difference from external proangulation to internal proangulation standardization procedures. But what we do know is by the reproducibility of the technique that it's much, much better.
That's how you mastered it in your lab as a core lab.
Well, yeah, as a core lab, but this is deployed.
But you replicate that as well.
It's deployed, it's deployed internationally.
Is firewall enough? Just the ASC?
I'm not wedded to any one segment. I mean, when you want simplicity, which is what I think doctors need, if you want my opinion, about how to get this into clinical practice, then it's simple. The data support that far-wall common carotid is just as predictive as any other segment, individually or combined. I showed that data of the studies that have looked at that.
So you would go with it?
Well, I'm not making recommendations.
No, for practical purposes, for primary care.
For practicality,
screening.
It's simple. Oh, absolutely.
Yeah.
And like I said, you can.
But we have discussed at length that IMT is a bigger predictor than plaque.
Then plaque, right.
And the whole idea of doing multiple segments is to identify the plaque. So I agree that if you just restricted yourself to firewall and CC, you would get the far. It's the most simple way, easy to teach, easy to learn, more reproducible. But our idea here
It's not comprehensive, right?
But if you just do a plaque screen and you identify the plaque, and then you focus on one wall of the far wall, and then
Measure,
you can absolutely
and measure
measure
it.
that. I think that's.
Well, yesterday you saw Henrik's presentation. It was fantastic. That many plaques.
Right.
I mean, it's not fantastic to have that many plaques, but it's great that they were easily detected. Paul, I think you're the last. You're going to close our session.
No, I just had a question in the name of simplicity. Why, instead of aiming for all these angulations and internal, external reproducibility, not aiming for imaging the thickest portion of the distal coronary, excuse me, not coronary.
Correct.
At any time that you see the patient over and over again, you'll see the thickest point.
Okay. So that's a great question. Okay, and that is one of the fallacies of athro imaging. Okay, so you can't do a subject at point A and look for the thickest part of the wall. Okay, that's okay because that's a cross-sectional. If you use it cross-sectionally, that's okay. But when they come back in a year or 2 years or whatever you're doing, okay, and repeating, who says that part of the wall that now you find being thicker is the actual same part you imaged at baseline? And that's the problem with that. So the goal is to focus on getting back to the same exact spot that you imaged initially. And that can be done. It can be done reproducibly. And it may or may not be the thickest, again, on repeat or not. It really depends on the biology and the treatment and whatnot. So that's the reason. Because then you don't know what you're imaging and measuring. Are you imaging and measuring actual change, or are you just looking for that thickest part and you're just technically driving?
What you're measuring is changes in the plaque that you have identified that over plaque, or the segment that you have identified the first time around. what I'm trying to is changing the patient's status. And that may be more important than just imaging one section, one end, one. You see what I'm saying? If you have identified this segment of the distal carotid artery for me as being the segment you want to image again, I understand that you want to say to measure the change in that particular segment. In the meantime, I may have grown 300% in a previous segment or in another segment, and that does not necessarily tell me that I've improved.
Absolutely.
That's a good point.
Absolutely.
So yeah,
There's no argument.
on a local segment.
We know absolutely that atherosclerosis does not change uniformly within segments, across segments, and across vascular beds. We published a paper, I don't know, 15 years ago, with some of our angiographic data that kind of shocked everybody at the time, because what we'd show in one segment, let's say the LAD, which would look like vascular, so would look like regression, okay? And it's a complex issue what really is regression when we talk about atherosclerosis. But what looks like, you know, percent diameter stenosis change based on quantitative coronary angiography, and then so we get better flow going down the LAD, and then on the right coronary, what happens? When we get quote-unquote progression, because the vessel in a compensatory way constricts.
I think we
Yeah.
can put,
But my point is, the only way, Paulo's right. I mean, the only way, if you want a comprehensive knowledge of atherosclerosis in the carotids, you have to go back to how Tasnim originally learned it, back in the ARIC lab. Every segment, every wall, bilaterally. But, you know, in those days, I don't know, you know, when they first started doing the training, it was a 2-week course. And they were charging the government to train people $30,000 per people. I mean, it was a great moneymaker for Wake Forest at the time. Okay, and I'm not coming right or wrong. It's just the way it was done in those days. So you're absolutely right. But the question is, is that deployable in practice?
no, we can't afford
It's not.
Right. Well, I think yesterday's presentation was quite promising that we might, come to a point, follow the same kind of images that you get at CTA, they might get with this new 3D, 4D kind of ultrasound, then a lot of these will be addressed. So with that, let's take a break, and when we come back here, we'll, Matt and Dan.
Just a closing comment. I think just as with the CT, with the carotid studies of ultrasound, quantitative measurements that are automated is the direction we should be going in.
And that's the 3D will bring the quantitative measurement. Please help yourself. I think there is still some limitations are left, and our plan for creating consensus has changed in such a way that we create minutes. It will be circulated, but at the end of today's meeting, which will be in the next hour and a half max, we will have a review of the summary of the changes that were recommended, both on yesterday's consensus and for today, which primarily deals with adoption of the test, training, certifications, and so on. So the two presentations that are left are going to be primarily Matt and Tasnim. I don't know if you have any presentation with regard to reimbursement, but we can tailor it to comments.
Yeah, I think most of what I had has already been discussed.
We already discussed, that's great. So, and then we will very much would love to hear about what NIH is going to do with the study. So that's what Matt is going to tell us. Matt?
All right, so just briefly, I want to go through where we are with reimbursement. And I think it pertains a lot. I'm going to cover a little bit of the European sentiment as well, as best I know it from the prevention guidelines. The benefit, obviously, that we've had and the successes that we've started to have following up on Mort's success in Texas has come from just a lot of published data and a lot of outcome studies that have been consistent. So from a reimbursement standpoint, we've been able to successfully move from temporary codes here in the United States to level 1 codes, meaning that they have a valuation. The valuation is then kind of expected that that Medicare and other providers will cover these level 1 codes. We have, for calcium scoring specifically, we have a code that's 75571, so it's just for the calcium score. In 2009, it paid $185 from Medicare. This is the CMS, this is a US-based reimbursement. It's gone down a little bit as everything in 2010 has been lower than 2009 for all imaging modalities, and it was subsequently re-increased by 20%. So it went down to about $100, and now it's about $130 for a study.
What's the indication?
The indication for calcium score is, funny you should ask, there are 3 indications. This is not only for California, but these are the 3 indications that Medicare will pay for. Number 1, they don't do screening, right? Medicare doesn't like to do screening, so calcium score is not approved as a screening test. It's approved as a triage tool in patients, as a quantitative evaluation test to use as a triage tool for lipid lowering in patients with intermediate to high Framingham risk score. Okay, so we think about shape. This is a triage tool. The higher the calcium score, the lower the LDL. It's a triage tool for lipid lowering. That's how it's being used. In asymptomatic patients, now they require 3 risk factors. Age being one of them, 2 risk factors, including everything: hypertension, family history, lipid abnormalities, smoking, obesity is a risk factor according to CMS. So it's a little bit loose. I've not had any problem getting any given 65-year-old who has Medicare to not have 3 risk factors, because they all have hypertension, so that's 2, age and hypertension. So if they're obese or used to smoke or have a lipid abnormality in the general sense, it is a covered test. Some people say they can't get 3 risk factors. I don't see how that's even possible, but that's fine. Family history of cardiac or vascular disease, right? So that's pretty broad. You can imagine different vascular diseases people may have. Their uncle had a positive IMT, they have vascular disease, so
uncle is family history?
I'm sorry?
It's a first degree relative, right?
It doesn't have, no, it says family history of cardiac or vascular disease. This is the actual guideline that was written.
And Matt, there's no
Ron Carlsberg wrote this.
There's no age on the family history?
There is no age on the family history, and that is it. It is loosely written. That's the language, and that's been approved by CMS.
This is just the California LCD, or is it?
Well, this has now been, this is the CMS, this is now being incorporated. There's not, we're still working on the national coverage system.
5 Western states.
Right, 5 Western states, but also calcium scoring is covered in 7 other states, including New Jersey, Florida, Illinois. So it's not quite all, but it's getting there. And other LCDs, other limited coverage decisions are incorporating these. It's also covered for 2 other tests. It's a triage tool in patients with chest pain to look for unknown etiology, kind of what Dan was referring to with the NICE guidelines from Europe. The UK guidelines also talk about using calcium scoring. If you have possible chest pain of suspected cardiac etiology, you can use a calcium score to determine the appropriateness of coronary CTA versus catheter coronary angiography, and equivocal stress testing. So where we might think CTA may be better, calcium scoring is an indicated procedure. And again, so far 12 states cover calcium scoring by Medicare, and Medicare has a payment coverage for it. So it's actually going to get easier and easier now that the level 1 codes are out there. United Healthcare is even better. This is the national policy by United Healthcare. This is the policy number dated January 1st, 2010. I'll be glad to send you the entire policy. This is the coverage rationale for calcium scoring. Calcium scoring, 16 or greater slice or EBT is proven for the following: risk stratification in asymptomatic patients with moderate risk for CHD based on Framingham score, or as a triage tool for symptomatic patients to rule out obstructive disease and avoid an invasive procedure. So, not a screening test, right? It says at the bottom, coronary calcium is unproven for all indications, including routine screening. So the U.S. preventive task forces that say not everybody in the world should get a calcium score, arguably correct, is reinforced here. But risk stratification in asymptomatic patients with moderate risk for heart disease arguably is a screening test, right? So it's a large population, arguably the SHAPE population, and they don't go into exact details as far as what the thing is, but obviously the implications would be intermediate risk is mostly considered 10 to 20% Framingham risk. So something we need to think about as we incorporate SHAPE and what can be done and what's already covered. Now the European guidelines, 2007, these are the preventive guidelines that were already shown, says calcium scoring is especially suited for patients at medium risk. Paolo still here? Paolo like this. And Harvey, the U.S. Society of Atherosclerosis Imaging recommends coronary calcium scanning as an initial diagnostic test in individuals 65 years old with symptoms atypical for ancient or unknown CAD. So the SAI is getting a special mention here. I don't know where they came up with that. It's a quite a little misquote, but they did get the rest of the society name right and everything. So anyway, SAI gets a little.
This is European what?
This is European prevention guidelines. These are,
It's not recommended.
oh, so right. So then they go on to say this. So you guys have a little bit of work, Raymond, here. Although calcium scoring is widely applied today, it should not be uncritically used as a screening method. Prospective studies. Now this is 2007. Prospective studies do not exist. With today's knowledge, these studies may be even considered unethical. Okay, so, well, now we have prospective studies, right? This was 2007, New England Journal 2008, Bob DeTrano published Mesa, Raymond hopefully 2010, Jack will publish. It will be, I know. I'd like to see it in press. I read it already. I'd like to see it actually in the paper, but hopefully we'll have a couple more papers that are large prospective population-based studies to say that this is no longer correct. But you're right, the Europeans do not currently recommend it, but that was arguably before Mesa and some of these other recommendations.
Now, Matt,
Please.
Back on United, it looks as though if you had an equivocal chest pain and an equivocal nuclear scan or stress echo, you could get a calcium scan and see no calcium because it would avoid a cap.
Absolutely.
Would you interpret it?
Yeah, so triage stroke for symptomatic patients through all obstructive disease.
So
and avoid
even if they've had it, on the way to if they had a test that might otherwise have taken them to the cath lab, you could
Right,
get.
absolutely. And that's, I think, that's where their rationale, if you go read the whole thing, is based upon sparing people from needing a cath that may be unnecessary if the calcium score is 0. So it goes a lot along with the lines of the NICE guidelines. Lower probability patients, calcium score 0, don't get a cath. It's a filter prior to invasive angiography, something that Dr. Albero made famous about 10 years ago. It's a filter prior to invasive angiography. So anyway, so real quickly, so this was kind of interesting. This is February 2005. This is California Technology Assessment Forum. So Blue Shield and Blue Cross hire hire physicians that are independent to come up with a technology assessment form to come up with should we be paying for this? And this is what they say in their technology assessment form for utility of calcium. They say the use of EBCT, and this was 2005 based on earlier data, the use of calcium scoring, or EBCT to measure coronary calcium as a screening test for asymptomatic patients who are at intermediate risk meets technology assessment criteria 1 through 5. It was approved. As a diagnostic test in patients with symptoms suggestive of coronary disease, is a useful technology to predict patients who have underlying coronary disease and meets technology assessment criteria 1 through 5. Those are the criteria you need to get reimbursed. To assess response to therapy for coronary heart disease, in other words, progression of calcium, does not meet criteria. So they said, yes, it is a screening test and it should be paid for, and it is a diagnostic test that can be used prior to invasive angiography to determine who has heart disease and who does not. So the same as United, except Blue Shield has decided not to accept this technology assessment forum's recommendations. So they say they hire these groups. Now, strangely, whenever they say it should not be covered, they've unanimously approved those and said that's their rationale for payment determination. Now, we had an independent group say it's not worthy, so we don't pay for it. Now they had an independent group say it is worthy, and they say they're not paying for it. So we're using this against them here in California, at least, to try to leverage the insurance commissioner to force them to pay to because their independent committee voted unanimously that as a screening test, it meets correct technology assessment criteria. So the funny story about this is I went up there and presented data. Their initial assessment from this guy, Jeff Tice, who works with Rita Redberg, was they should not pay. And I showed them all the data, and they changed their mind, and they all voted in favor of calcium scoring, which is unheard of. They never change their mind at these things, but they all voted in favor. It was 9-0 for screening and 7-2 for diagnostic test. And then as I was leaving, after we won, I thought Blue Cross would have to pay from then on. I was very excited. I left going around the airport. I see Rita Redberg literally running across the parking lot to the meeting site, but the vote was already over. So she was trying to show up in time, but she missed the vote there. So anyway, so we have a positive public, and that's a public statement by Blue Cross or Blue Shield that it should be covered, but they don't pay. So I use that for my patients in California, at least, to say Blue Shield should pay because their technology assessment forum said that they should pay. Anyway, Aetna, not as positive. They do consider calcium scoring necessary for diagnostic CT angiography, but they say that calcium scoring, no matter what device you use, is experimental and investigational for all other indications. And this was published in May 2010. So, right. So this is Blue Cross's policy as well. Blue Cross hasn't reiterated their policy lately, but they call it experimental and investigational. Has not been established in the peer-reviewed published medical literature. So the Society of Cardiac CT has decided to wait until the ACC paper comes out to then go back to United to leverage them. Because we'll have a stronger hand once ACC
What
recommends
was
it.
the basis of the Aetna decision? Did they have a team of cardiologists as well?
This is their CT, I don't know how they do it, these things, but it's great. I mean, this is the thing we're still facing. This is May 10th, 2010, experimental and investigational, because it has not been established in the peer-reviewed published medical literature. So, I mean, honestly, there has to be 2,000 or 3,000 articles. I've lost count. I used to be able to read them, right? I mean, when Paolo were writing articles, there was one a month maybe that came out somewhere so we could all keep up. Now there's, who knows where they're being published these days, in radiology journals and prevention journals and everywhere else. So we need, obviously we need to deal with the Aetna and Blues a little bit directly still, and I'm waiting for the ACC before we come back. But Aetna came to us, to the site of cardiac CT, and said, we want you to look at these policies, and for CTA they were very favorable, which is remarkable because there's no outcome data with CTA at all, and they're paying for like everything with CTA. They have the most liberal CTA policy of any company.
United's pretty good too.
United's very well good too, but Aetna's even better than United, but at least United's paying for calcium scoring. I mean, if you're going to say you need evidence, we have more evidence with calcium scoring than CTA, right? At least evidence of outcomes and diagnostic accuracy. I mean, everything. We have more patients that we've studied. So it's just remarkable to me. So one thing I just want to show you real quickly, and this is one that I'm going to start using in our debates, and I'm going to make sure, I think that this has to be strongly reiterated in SHAPE if we are going to advocate for calcium scoring, is the fear of downstream testing is not ever been documented to be a reality. Here's the reality. This is the best study you can ever find that will show how much downstream testing occurs. This is coronary cath. This is 3 years, a 52-month follow-up after a calcium score in 7,000 patients. The MESA study, published in JACC Imaging, 2009. There were eight patients out of 6,614 who went to the cath lab because of their CT results. 8 out of 6,800. So the math is 0.1%. So the downstream testing is remarkably small. Of the 175 people in the whole trial, right? The whole trial had 175 people. 2/3 of them went to the cath lab because of either an MI or angina. Nothing to do with, and the average follow-up, and that time from calcium score to cath was over 18 months. So it wasn't even driven by the calcium score at all. So if anybody says there's downstream testing concerns, and the Europeans have voiced this as well in their paper, I'd just like to see the paper that they refer to. I mean, to make these claims like Rita makes, that downstream testing occurs. without any scientific evidence is not acceptable anymore, and we have evidence to the contrary. Dan has evidence coming out with the Eisner study, which arguably, you know, in Cedars-Sinai, you know, downstream testing does occur, and even there, the downstream testing was quite minimal.
Jack that was in Jack last year.
Yeah, so that was also in Jack. So we have papers now to document downstream testing is minimal, and the people who do get downstream testing, for the most part, do end up with ischemic, positive ischemic tests and get revascularized.
What about incidental findings?
So incidental findings, well, in Mesa there were no incidental findings.
There was no.
Right, because I was the core reading lab for Mesa. We didn't see
See, the
any
major
incidental findings.
problem with many CT papers that there is incidental finding. You may see a lot of some in the lung. Or
Right.
something.
So, I mean, that still, I think, needs to be figured out. But calcium scoring, that's not as big a problem as CT angiography, right? And I don't think that issue hasn't come up in calcium scoring as much as CT angiography.
Why is it a bigger problem in CTA?
Thinner slices, contrast resolution, better spatial resolution, because you're getting finer cuts to see nodules. So the nodule detection rate is always much higher with CT angiography than calcium scoring. Calcium scoring is thick slices, not as many cuts, 30 slices of data. So we haven't had that same issue come up as much. There is still a potential issue there.
And the contention that somebody may have who's against the use of calcium because they may produce downstream downstream further testing, is that this type of results, or the results that Dan publishes, come out of good places, you know, places where I work, you work, he works, and we know what to do with it.
Right, but that's the beauty of this. These doctors had no idea what to do with this.
I know, but that's the contention that I hear all the time. Oh,
Right.
you do a good job, but just give it to the general population and see what
Right, but this is the exact opposite. That's why this is the perfect article to show them. So,
Where is it from?
this is from Mesa. So what happened in Mesa? Random people got recruited to 6 sites. None of the 6 sites had CT expertise. None of the 6 sites. They were not my center. I'm not a CT recruiting site for Mesa. I'm the reading center, but I'm remote. So this is Minnesota. This is Wake Forest. This is Baltimore, Maryland. 2001, they did not even have appropriate CT equipment in place. These patients were recruited from the general population. These results were sent to their physician, who probably had no experience at all with calcium scoring. This is not 6 expert centers. This is the general clinician who is getting the test that he didn't even order. And this is the result of that test.
Where do you have this publication? Oh, in
This is Jack Imaging, but Boaz Rosen. Rosen was the first author. This is the perfect answer to the criticism. This is not my center and me dictating what should be done. This is random doctors and random patients out in the community in 2001. These scans were done in 2001, 9 years ago, and that's the downstream testing, 8 casts. I don't think that's contributing much to the overall problem we have in the New England Journal of Medicine 2010, where most casts are negative and being done inappropriately.
Can there be any slight argument about carotid assessment and downstream? We know the carotid.
Right. We can probably look at that in a study like Mesa, because we did carotid IMT. We'd have to figure out what the downstream test you want to look for is.
There is no downstream test.
No, there are downstream tests.
There is no incidental finding.
Well, there might be people got carotid revascularization, or who knows what after the carotid testing. Right? I mean, there are theoretical tests.
Those are downstream procedures.
Right. Well, I mean, that's what you're worried about. You're worried about dollars downstream, right? So taking an asymptomatic person, finding a plaque in their carotid, and doing a carotid endarterectomy would trump my 8 casts that I got out of calcium scoring, right? So if that happened once in Mesa, that's much more expensive than these 8 patients.
But those are therapeutic interventions that you have to have because of existing guidelines.
I don't know, asymptomatic people with plaque in their carotid.
Well,
No, asymptomatic with 70% stenosis.
Yeah.
That's a recommended.
Well, I'm saying, but you're going to have a...
That we viewed in a positive light, actually.
Right, but how many people got... We don't know, we didn't look, but how many people got diagnostic tests to confirm the presence of plaque or thick IMT in a carotid test? And I don't think we know that data, right? I'm not suggesting it's high, but I'm suggesting there are downstream tests that are done, right? What do? So you see a plaque in the carotid, You do a follow-up carotid duplex, because this wasn't a formal carotid duplex, so that's some testing. And then maybe you do a CTA or an MRA to confirm that before you send them to the OR. So that's another downstream test. I'm not saying any of these are inappropriate. I'm not even saying these 8 are inappropriate. I'm saying this is downstream testing. People aren't worried about the appropriateness of it. They're worried about the cost implications of the screening test. And I would argue that there are cost implications of a screening test in the carotid as well as in the coronaries.
Well, those are things that we have to do. Otherwise, there is no reason to do screening and find somebody with 75% now when you don't do anything about it. So,
Right, but how many people just read thickened IMT went on and got additional testing? Right? I mean, maybe not appropriate. It's got to happen, right? I mean, who knows? We have to figure that out. So I'm just saying that we don't know. I don't think there's any papers on it. And I'm not raising that as an issue, but there must be downstream testing after IMT. We know there must. It's
not IMT, but after, generally in IMT, basically, I think you guys can say what less than 1% will come with more than.
Yeah, that's a good point. I think it depends on what your catchment is of the patient. So the prevalence of having a 70% or greater lesion would be very low in that population. So yeah, I think, but that would be then the one that you need a duplex to confirm it. And many surgeons may operate just on the duplex. Sometimes they will order an MRA and so forth. But the prevalence of that kind of finding is not going to be high in your screening population.
But I think the biggest potential of testing after IMT screening is a duplex ultrasound, because
unnecessarily a lot of
well, I
people
mean, the thing is, you could have done it at the time of IMT testing, but you are not really qualified to do it.
Yeah.
And so if you
and
see
you
any
don't
plaque,
need
you
it.
really
Do
you don't
if
know.
you're 5% or 10% or even
Right,
20%
but sometimes the
now,
plaque does not tell you how severe it is, and you really have to do doctor evaluation.
well, do you have to do that if you're only 10 to 15, 20%
What the question
plaque?
is, do you have to do it, is does it happen? And the answer is it happens, right? With an unknown prevalence, it happens.
Well, I think we will have
An undocumented prevalence, it happens. It has to happen. Everybody's going to say in this room, it's never happened,
No,
right?
we
So it
have to
happens.
provision that in shape 2, saying if you find a
gonna
plaque 10%, 20%, you don't need to go get duplex. Because, I mean, this is the
But then you
range.
try to
But
reassure
you
them.
can't tell if it is 10 and 20%. You see, that's the problem.
I think it depends on the operator. I mean, if they're experienced, they
Right.
can get a sense that something else needs to be done. But a lot of the time, the operator and then the physician reviewing it can make a judgment that this does not. And they can even run a preliminary Doppler. That's what we do at Mayo. And we then don't want to tread on the radiologist's
Exactly,
toes.
that's the problem,
And we
is
then
to
say,
tread.
you have to have that. So that's where that's a duplication. But in my practice, the vast majority are not referred.
Right. No, but when we started this service at Cedars, it was our understanding with radiology that we are not going to do vascular ultrasound. And so whenever there was a doubt that, I was dying to put Doppler signal and see what the velocities were, but I was not doing it because then, I was treading on, exactly. So I was referring them on for a formal Doppler exam.
And what was your trigger for referral? That's what.
A plaque which is concentric, which you really cannot tell
Okay.
what percentage it is. Sometimes you can tell, but a lot of the time you can't tell unless you do a Doppler
Is that
evaluation.
right? A lot of times, like 80% cases that Henrik Sillison presented yesterday out of 6,000
Right.
HRPs, and do you think a lot of them would have, out of those plaques, a lot of them would need duplex? Because if they do, we have a significant responsibility to elucidate that.
Well, I think you need to is mention when it may be appropriate and when it's inappropriate to go on for further testing,
Right.
not on the calcium score, but with carotid IMT, because obviously, and Tasneem could probably look back at her studies and see how many she did refer, what percentage of patients did need a referral. And that might be important information for SHAPE.
Yeah, I did, I think very much.
But I think if you want to prevent this downstream testing for IMT, really you have to train your own people to be able to do that. It's just a press of a Doppler button. You have to be familiar with the Doppler angles that are needed, and all they do in the vascular lab is look at the numbers anyway. They don't do anything sophisticated. If your peak Doppler velocity is 250 centimeters per second, your stenosis is 70%. I mean, that's how they diagnose it. So that's all you need to do, and again, there needs to be a little bit of training in order for that too.
But arguably, there may be labs that are just doing IMT that are not.
Yeah, well, that's what
doing Doppler,
that's
right?
what we were
Right.
talking this morning, that wide adoption by primary care practitioners. Let's say they learn in one day through Howard's magic way, getting up to speed, but then what to do with the plaque? Because we're not telling them duplex.
Well, Germans are doing, they're doing a lot of IMTs.
No, they're not doing duplex.
Right, no, so they're doing a lot of IMTs, so we might figure out the downstream testing.
I think that is what you said before is very typical. You do IMT, and of course all the machines have in addition the color Doppler possibility, and the physicians and the cardiologists all will do color Doppler.
But that's for
I think
diagnosis.
yes, because they don't restrict themselves to IMT, because they can also look to Doppler, and color Doppler is reimbursed in addition. So of course they do ultrasound and duplex. Possibilities, but there's no indication for the duplex.
That's direct downstream testing.
That's
There it is.
an immediate
You just doubled your cost of your IMT by doing an extra test, right? We can't do it.
I don't think so want to recommend that. I recommend that.
Well, that's right, we need to specifically mention downstream testing for both,
I
and
think
the evidence available.
I think doctor, you had a really good point, Matthew, that the doctor duplex assessment should be considered downstream testing, because
Yes, they should be.
it should be considered
It
downstream
is.
testing. We will have to
Should be
limit
more money for it,
it.
yeah.
We will have to limit.
Right.
We will have, Jim.
Well,
It's a
on that
complicated
point,
topic.
you know, the practices that I know of that are doing carotid IMT look for every opportunity to do the color Doppler to substantiate the bill. I mean, they know that it's going to be rejected, so if they get an opportunity to now call this, so it's not like they look at it as downstream revenue, they look at it as like an opportunistic.
Well, those cases you said are legal. So
Well, no, I mean, no, I'm not talking about that part of it legal. I'm just saying that if they see something,
yeah.
they're
They're
going
trying to make this a symptomatic or somewhat suspicious case so they can get.
Well, they want a procedure that's covered by insurance. I think one of the ironies that we're also talking about that we need to address is not only with data like Matt just presented as far as how few people actually get in Mesa and other things, but the irony is that the very doctors, whether it's Bono or Redberg or others, and people in practice who are the most vehement and vociferous critics of the downstream revenue are the ones who are most likely to pervert any calcium score into other tests. We found that in Denver, where you had cardiologists doing caths on people with minimal scores, asymptomatic, right? And then complaining to the insurance company. This is just leading to all sorts of testing.
Right.
You know, so that's a real issue.
I think.
Yeah, I was going to say, I mean, I think this is where SHAPE is going to be, and I think Mark's going to be sitting back one day, hopefully. That SHAPE is self-evident, but I think this was a prudent quote I'd like to finish with.
That's a nice dream.
So we'll see.
One day we come back and say all of these were self-evident. They knew before even you had to talk or write paper.
And then study it all.
Yeah. So I was going to ask everyone to continue the discussions here. Just see anything that we can give to Matt, though he's not the director of that committee, but he's our only hope at the NIH level to change the direction or influence on this long anticipated study. This is study 4 years ago, 2006, was the focus of our SHAPE AHA meeting, the SHAPE trial. And we were very straightforward. We said, okay, if you don't agree with our guideline, why don't you come here and help us raise capital and fund for a trial that compares SHAPE with the status quo. We even invited Mike Lauer. He agreed first to come to the meeting, and then a week before he sent me an email, sorry I can't come, and we couldn't get anybody from the other side of the fence to come to the meeting. So I think the evidence and this editorial by PK and the counter argument from Lauer, I think set the stage. And now we are at the level that we can push for a study.
Right, so let me just, I'll tell you, so right now we're finalizing so the NIH asked Phil Greenland to organize a group from Chicago, from Northwestern, to organize a group to come up with basically an NIH grant for primary prevention to test the algorithm of screening. So it was a Framingham versus screening study. So which one is going to lead to better outcomes? It's an outcome study. which arm has better outcomes, which arm has more people alive at the end of the day, etc. So the group got together, they had a pretty broad base of experts. IMT was represented, I was there for calcium along with other people. They had people like Sanjay Kaul and George Diamond there. So they had a pretty broad-based group there. They decided to go down calcium scoring versus Framingham. So it's basically 6 to 20%, the way it is now, it's 6 to 20% risk versus randomized to either Framingham treatment. So Framingham would say don't treat or treat mildly versus a calcium score. And the calcium score may say to treat very aggressively or treat not too aggressively. It's kind of a shape algorithm where the calcium score will dictate the level of lipid lowering in that arm. And they're going to be followed. Phil Greenland and Tamara Polanski and others over there in Northwestern have done some very nice power analyses. They've decided that it'll probably be 45 to 75 years old. We're still working on some of the final logistics, but they've got a power down that the NIH can swallow as far as funding. They decided to go with calcium scoring instead of IMT because the predicted power of calcium scoring is higher, so they need less patients in the trial to prove the algorithm. That was their assessment. They've decided to do away with CRP as part of the treatment arms. And Sanjay and George were strongly advocating for a treat-all arm where 1/3 of the group got treatment no matter what. And that was also deemed not very prudent, and they decided not to go ahead with that arm. So it's going to be a 2-arm trial, Framingham versus SHAPE, but SHAPE being specifically calcium scoring. The higher the score, the lower the LDL.
With therapy initiated and controlled by the private physician or standard protocol?
So that is one of the final issues of whether they want a protocol-driven. It's going to be protocol-driven, so it will tell them what to treat, but whether or not it's a randomized trial where they follow them routinely and dish out the medication, or just tell the clinicians what they should do. But when they're in that arm, what they should do typically happens, right? We have a lot of statin trials that have been done that way, where the recommendation was high-dose therapy versus moderate-dose therapy, or usual care versus high-dose therapy, and they don't always get to exactly the goal we hoped, but they kind of follow those guidelines. So
how many patients or how many years?
So the power is being finalized based on the final entry criteria. We'll know more on September 17th when I go back to Chicago to meet with the group. But I think the last number I was looking for before, I couldn't find the exact number, but it's in the over 10,000 person trial. It's a big study. Well, it's going to be a big study because you're proving treatment versus treatment, right? I mean, this is incremental therapy.
So
I think it's 14,000 is the working number.
Target for therapy is really key here because
Right.
in SHAPE we have 2 things. One, we identify the disease, then we tailor the treatment to the severity of the disease.
That's going to be it.
If they don't implement this kind of
No, that's what it's going to be. It's going to be an atherosclerosis test. So they're going to. Step 1 is going to be Framingham risk 6 to 20. Step 2 will be a calcium score, and step 3 will probably be this exact treatment algorithm. The higher the calcium score, the higher the Lipitor. They're going to use Lipitor probably because it's going to be generic.
When are you randomizing? You're first taking a group of intermediate risk, and then you randomize
Right.
to see a calcium score
Or
or traditional treatment.
Exactly.
Well, there are for Framingham because they were based on Framingham intermediate.
Right. So this is half the arm shape. The other slide would show
NCP.
is 6 to 20% follow NCP guidelines.
Yeah. Okay. And diabetes, there's no diabetic in the trial.
They're going to exclude diabetes because that's already a treatment algorithm. They want to randomize them to 0, and then we get into the problem of Palo's data of a score of 0 calcium score in a diabetic. Do you not treat them or not, right? So you have a problem with diabetics. So diabetics are excluded. 6 to 20% excluding diabetics and high-risk patients who already need therapy. Because we're going to randomize them potentially to no therapy. So it's going to prove 2 things. It'll prove, hopefully, 1, that SHAPE, knowing the plaque, will lead to better, and part of their algorithm is it's going to better compliance in this arm as well, because they're going to see the calcium, they're going to show them the scores. So compliance will go up, and that will help, but also obviously we're going to tailor the therapy specifically. So if this works compared to SHAPE, compared to NCP, polypill idea will be less impressive because that's one size fits all, and this will be tailored therapy.
How do you avoid the issue that we were talking about with Philadelphia with the drop-in rate? People.
Well, the drop-in rate, the only drop-in rate will be is if they get a calcium score.
But I mean, how do you
They're
control?
going to get an NCP on the other side. So
No, but how do you avoid somebody who just gets NCP and says, "Boy, my friend's on Lipitor. I want," or you know, I have a feeling.
We're going to have that. I mean, we're going to have crossover both ways. We're going to have the non-compliant shape patient who has a calcium score of 500 who says, "I don't want to take Lipitor, 80 or 50, 40 or whatever," and you're going to have the person who has no risk factors who says, "Well, what the heck? I heard about this Lipitor on TV. It's generic now. I'm going to take it." So I think there are going to be some
Can you ask the
crossover.
patients not to undergo a calcium scan in the next?
I know, right. The implication would be if they're not randomized to that. So my plan is to offer all the patients at the end of the trial a free calcium scan, so that they know they're getting one if they want it at the end of the study to deter them from getting their own, but they still end up with that information at the end of the trial. So at the end of 4 or 5 years, they can still get their free heart scan, and they haven't missed anything by being randomized one way or the other. Because obviously we're going to be blind to the calcium score.
Assuming they're alive.
Assuming they're alive.
Okay, so this is a 5-year study?
Right, so the last thing that it may prove is de-escalation of therapy. Because now we're going to take patients who have Framingham 17, 20, or 18% risk, calcium score 0, no therapy, and we're going to be following those patients. So this will go back to the debate that Harvey had with Sanjay yesterday. This may prove that a calcium score is safe as well, because a 0 score is safe.
Are these statin naive patients?
Yeah.
Everybody is a statin naive?
I don't know if they have to be statin naive. Probably they will be. Yeah.
They should be.
They should be. Yeah.
In this group, maybe we should try to incorporate the IMT based on what we got from HRP trial, that if their coronary calcium is 0 and their carotid IMT is full of plaque, they should not just continue with the shape doesn't recommend.
So the problem is that Phil Greenland is enamored with MESA. And MESA says that if your calcium score is 0, you cannot have an event for the next 5 years. That's the MESA data.
Well, I think
That's just the event, that's the data.
I think it's our.
So that's how they powered the study. You cannot have an event. The event rate was 0.07%. 7 out of 10,000 patients had an event with a score of 0. So to find those 7 out of 10,000 is not going to be done with carotid IMT. I don't think you're going to find those 7 patients. Those 7 patients could have an embolic event to the coronaries, could have had spasm, could have anomalous coronaries, anything else.
But there would be.
It's not all atherosclerosis, right?
Those
It's
7
problem.
were coronary, but there were a lot of cerebrovascular patients that you could have prevented. And if you have a lifetime opportunity to prove shape versus NCT,
This is a 5-year study, Mort. It's not a lifetime study.
No,
It's not going to work.
No, but they're not going to spend money like this again.
Just like
This is
Mason.
an ideal opportunity.
No, I know, but I'm telling you, I mean, Alan Taylor was there. He was advocating for IMT strongly.
Not everybody. And the new shape that we created since yesterday says if you do coronary calcium, if you're 0, you can go to get IMT.
And your risk factor is more than 10%, let's say. You know?
Yeah, and then you are intermediate risk.
Correct.
If we get to that level, then you have the, because that's the only place we could be.
Okay, so if 70% have a positive scan, Mort, then everybody's treated, right? We know that. HRP said 70% calcium scores of 0 have a positive carotid scan. So I can't go and advocate that nobody's a 0 anymore. That's not going to work.
Well,
The
that's
NIH is going to say that's ridiculous.
That's by his 3D method. That's by his 3D
Okay, so should we only do IMT? Should we only do Howard's method of Farwell
Can we do a
IMT?
sub- can we do a
we haven't
sub-
picked up on this. Okay, but here's the problem. From the NIH's problem is there's no consensus on how to do
That
IMT.
is true.
Okay, so you got 6 experts in the room, world class. They can't decide what the best way to do IMT is.
No, that's not
That's
correct.
true.
I mean,
What's
there-
the- what's the
But
consensus?
he's right. We don't know what, plaque is going to be present in many people
Okay,
with
so-
coronary calcium of 0. The question is, how much does it have to be before you start paying?
Right, we
There's
need a
no data.
consensus
We
more,
don't
a
know.
threshold.
It's a done deal, isn't it?
No, we have September 17th, or we have some time before. The NIH hasn't funded, the NIH hasn't said, this is the set protocol, we're stuck. I mean, but the problem is that still to this day, my problem with IMT is that I can't read a consensus document and find out, should I read just far wall, near wall, common carotid, all three, 3D, plaque over 50. I mean, what's the right answer? And there is no right answer.
Well, if the IMT is more than 75th centile, that's an easy answer, a relatively easy answer. You know, IMT 75th
of course,
centile,
I mean, there's a large...
ICA, bulb, and ICA, 3 areas, you know, has to be composite.
I'm just saying,
That's
that has to
the
come
that's
from
the
ACE, or that has to come from some organization, right? I mean, that's the problem, is there's not a real great consensus on exactly how IMT should be done, how it should be reported, and how it should be used in clinical practice. We have a little bit more of that with calcium scoring because calcium scoring was just very simple. Arthur Agatston, you know, nice guy, you know, just made a very simple total score, and that was it. And we've been doing that since 1990 the same way. We're using the same Agatston score. In 2010, we're starting new clinical trials using the same old Agatston score that he published in 1989.
Okay, so Matt, you have a point, but here's the thing. If this is a lifetime opportunity and the NIH comes around with it, is there any way we could incorporate the IMT, the carotid ultrasound study just like HRT did? At least put it in a trial.
I think that'd be great.
Just put it in trial the same way. We just get Bob Lister, he can give you all the protocols. Henrik will give you, put it in the trial, at least we collect the data, and then 2 years later.
You don't make decisions based on that.
Yeah,
right.
You don't need to make a decision. And it doesn't cost that much.
Right, I mean, right. Part of the problem again is this is based on Mesa and whatever, Dan O'Leary, good, bad, or indifferent, didn't have whatever. His IMT data wasn't very impressive.
IMT data wasn't, but I think
but the IMT methodology that a lot of these people present is based on just the IMT without plaque. You see, and that creates a problem. But you're right. Plaque, how much plaque is abnormal is also not.
Well, Mesa will be getting better too. Jim Stein is taking over Mesa. So hopefully the new IMTs that are being done this year are going to be more than just IMT. And you know, I mean, if not, you should talk to Jim Stein about what he wants to do because we're just getting started with Mesa.
So he is part of this group also?
I don't know if Jim Stein's in this group, but he's in Mesa.
But no, this committee is
this
so
committee.
important. This is very important.
Right.
I think, Matt, we need to empower you with the data that Henry presented yesterday.
No, I think IMT is great. I'm just saying that it's hard to put into exact protocol if we don't know what the protocol should be.
He has the protocol. He
You
showed
can't
us
use the HRP protocol.
No.
Everyone has plaque, because 70% have plaque.
No.
The NIH isn't going to like that.
No, man.
Someone's got to be normal.
Collect the data.
Collect the data, ignore it.
No, collect the data, then you can go back and do retrospective analysis and all kind of things. But if you don't have the data, then we're lost.
We can try that.
I mean,
Observational.
right.
No, I think it'd be great to have that additional data.
You would then
Not
know,
necessarily.
you would then know how much
Not
plaque
all.
is abnormal.
Just you measuring their
A
blood
large
pressure,
prospective IMT trial.
Yeah.
But that part, but I'm saying, but the algorithm for treatment probably has to be based on something a little bit better vetted
No,
out.
there is no treatment based on IMT.
Right.
Just collect the IMT data.
Collect IMT and plaque.
IMT.
Well, if we do it, then obviously don't
Just do exactly what Henrik did.
Just so you know, Mesa has plaque. They just haven't reported it. I don't know why, but the data is there. They have plaque variables in Mesa. So if somebody wants to write up papers on plaque and what it shows, you can write papers on Mesa. Mesa's an open database. Anybody can write a manuscript on Mesa. You want to look at plaque and how often plaque was detected based on whatever O'Leary did, we can do that. They have plaque variables. They just didn't report it yet. I'm trying to get people to do that now. Taylor's gotten involved and other people have gotten involved. We're trying to go back and look at Joe Pollock. I think he's a big IMT guy. He's involved now trying to look at plaque in Mesa. But any of you know, world-class experts, anybody can get involved in Mesa and write a paper proposal. And PK actually wrote a paper proposal for Mesa recently.
Right. Let's focus on...
Sure, I'm just saying, but I mean, there's data out there as well that we can incorporate.
You know, Matt, I presented to the group, remember?
Oh, yeah, Steve was there. Steve's the partner. Joe, sorry, Steve, right?
I presented the ERIC data.
Right.
And we took a vote. There were 30 people. I got 0 votes.
Well, you need to vote for yourself then, Steve. That's not good.
No. Aside from the issue, there was no interest in now. The only
I tell you, Bill Greenland is enamored with Mesa, and that's the problem.
Now, but the difference now is what we heard yesterday, sort of Phillips 3D.
Right.
Now, the pushback I've gotten consistently on this was, and I wanted to go after the zero calcium people, the low end.
Right.
Is it costs too much and it takes too much time. It'll expand the study too far and it'll collapse it. That's been the pushback.
Okay, well, we can try to reapproach them and see what the costs are. Maybe we'll talk to HRP, see what the costs are, and maybe we can go back. You'll be there, are you gonna be there in September?
I am.
Good, so we'll have 2 of us there plus.
I got 0 votes, you know.
All right, well, we can work on that. I mean, I think
Even Alan Taylor didn't vote for me.
yeah, that's.
So-
Well, I'll tell you, Alan, so, I mean, Alan did a great job with the ACC. They were going to be stuck on a 2B or worse recommendation, and Alan really pushed it hard to get IMT up to 2A. So he is a big advocate, whether you believe his methodology or not. He's a big advocate in the field, and he's pushed the ACC in the right direction. But I agree with you, he wasn't there on that one.
Now, for the first time, we have a dedicated ultrasound probe for 3D. 3D.
Okay.
It has not been available before.
Now,
It could add something.
Pushback will be though.
What you say?
Well, we need to know the cost, right?
Well, no, again, what's the outcome data? He won't have the data yet.
No. You have a tool now.
No, that's not gonna work. You know?
Why not try?
See why?
Observation.
If, well, let's,
It's
wait, we now have,
That's gonna be a problem.
we now have a way to collect data.
I agree.
It's just very hard to push back and say, no, don't collect the data. We're not saying change the study design based on the result. Just collect the data. And that's a matter of logistics.
If Matt should take that forward, they'll listen to him sooner than me. I have no.
I can try to, I'm just saying, but I mean, we can both talk about it, and we need Alan on board as well, but I think if we had some of the HRP data, and we had the specific costs, that would be helpful, because I think just, we're gonna do 3D plaque analysis just sounds expensive, right? I mean, Tasneem has the 30 to 40 minute protocols, that just sound like it's gonna be very time consuming, and that's
No, but if you
part
have
of
the
the
most,
pushback.
then you can
I'm
quickly
not just
switch
saying,
and get it.
there's ways of doing this really well.
I think you have
Take
to,
a few minutes.
Yeah,
I think
a
you
few
have to
minutes.
build on what was done
Yeah,
before.
3 minutes to cut the data, that's.
It's just all different ways of doing it, is all I'm saying, and that's been
Well,
the problem.
our protocol is now about 15 to 20.
Right, I'm saying, but you did that extensive, you had at one point.
Yeah, that one was
Right.
an hour.
I'm just saying, but I mean, that was an hour, and that sounds like a lot of time commitment for patients if it's just gonna be an observational
Yeah, no,
arm.
let's not even talk about an hour, let's not talk about it in 15 minutes. It's gonna be, in the range of 5-minute quick test, and that's what we should push as much as we can to collect the data.
I think the nice thing about the NIH at least is if they decide, when they decide to get the trial exactly going, and I'm sure we've had conference calls, I'm sure they're committed to funding it, I don't know exactly the timeline. One, it's not gonna start tomorrow, so we have a little bit of time. Two, we can write ancillary R01s to add IMT to maybe not all 14,000, but to 5,000 of the patients, or something at selected sites. So I think there are going to be opportunities here to get this in before the whole study is done and over with. I think, as Steve said, it's going to be a hard sell to say these 14,000 patients, we want to add another layer of testing because they are looking at cost. It's a big study, right? Even for NIH, it's a big study. It's going to be a 5-year trial. It's going to include treatment, which may have to include LFT testing and all the other stuff for safety if they're going to advocate Lipitor and all this. So there are going to be some hard costs here that they're going to have to mitigate. But I think Mike Lauer and Diane Bill are behind this concept, and they want to prove it. I mean, Mike is saying we need the data, and we're telling Mike, then you got to give us the money to prove that it works. I mean, you can't prove that it's not good. I mean, right? Innocent until proven guilty, right? We're in the U.S., so that's how we're going to have to do it. So the algorithm works until it proves it doesn't work. So.
Thanks, Matt.
Anyways, that's where we are today.
Excellent finding. And so I think what we're going to summarize, because food is out there is looking at me, and we're going to make sure that we get the bottom line across everybody. Our plan is to create minutes of yesterday and today. The summary of our recommendations or changes for recommendation will be circulated. And those highlights will be approved, and we all agreed that these are the things that we agreed. Then we embark on writing, and the writing will be aimed at a manuscript, maybe a peer-reviewed manuscript, not too long, not as an attachment or a supplement to a journal. And within the summary, we also will highlight the importance of going for a younger population. the fact that the younger population will be a new window of prevention for SHADE. And there, we will also build the ground for creating another consensus. It won't be the SHADE focusing on identification of the vulnerable patient, because that's been our message, part 1, part 2, part 3, that will be part 4 of vulnerable patient. But vulnerable patient is focused on the next 5 years, prevention of events and so on. Whereas the larger window of prevention in the young population would be much more, I would say, subtle and not too confrontational, and probably one of the things we have is carotid IMT. We're not going to recommend coronary calcium in those age. So it would be much more politically accepted, and we won't have as much challenge, and that would be coming later. So for both of these, we're going to meet at the American Heart Association. We will have either a symposium to summarize, to present our summarized findings, or have a meeting like this, depending on how well we progress in the meantime. And plan is to get this published early next year, hopefully. Dan?
Yeah, I think we went through how we would reshape the shape, and then we heard a lot of new things. Do you think we should revisit, or is there plans to revisit this?
Yeah, I would, yes, I was, well, the plan was to write these up, but I think we should just take a 5-minute break to go get the foods and so on, and sit here, and we just go through each of these. And that's where I would like to have Jeff take the lead, because he's taken a lot of notes, and we summarize it. And if you have some time, I would love to have George's presentation on obesity during lunch. Our plan is to leave this place no later than 1:30, which was our original plan. Is that okay?
No, just very quickly. I saw the list of journals that you're proposing, and others is the last word there. I would like to put a plug in for atherosclerosis, actually, which is a very good journal coming up strong in the scenario. Sure. It's sponsored by the Society of Atherosclerosis Imaging and Prevention.
Okay.
And it might be easier than getting into circulation imaging or JACC imaging.
Sure, that's a good point, but don't you agree, if you're able to get it in JACC or circulation, they have better reach?
Yes, the problem is that big if.
That big if, right. So
it might be a good.
Yeah, PK said something, and we'll see if he can get that if from a big if to a small if, and so we can go from there. Okay, so
it would be hard, right?
Yeah, well, we're just going to see. Please get your lunch and come back.
And look at it, and I think we can understand many things what we are doing by measuring by carotid ultrasound, and in fact also with fluid deoxyglucose by PET-CT. Because we can see here we have media. It's what we measure the intermediate thickness. The thickness of media, it depends on hypertension. So it's correlated with hypertension. We have a foam cell lesion here, a lot of foam cells. We know that these foam cells is the first cells that appear, it's also the first that disappear when an induced lesion, and when we